Hello and welcome. My name is Sue Kressly, and I'm a practicing pediatrician in Warrington, PA, and the immediate past president of the Pennsylvania chapter of the AAP. In addition, I serve on several national AAP councils, committees, and sections, including the Council on Quality Improvement and Patient Safety, the Section on Administration and Practice Management, the Council on Clinical Information Technology, and others. It's my pleasure to speak with you today. Welcome to this three-part series on quality improvement presented on behalf of the PA chapter of the American Academy of Pediatrics and the Pennsylvania Medical Home Initiative. The PA Medical Home Initiative is a project of the PA Department of Health in partnership with the Pennsylvania chapter of the American Academy of Pediatrics. This is meant to be an introduction and provide you with background information so you can effectively embark on quality improvement in your practice. Part 1 in our series will look at quality improvement, what that really means, and where it started. Our learning objectives for this first segment are to understand the premise behind quality improvement, identify the key players that have QI as a core mission, and recognize other organizations that use QI and quality measurement. As physicians, practice managers, clinical and support staff, and other team members, we are all dedicated to improving the health of our patients. Quality in healthcare really is the link between improving what we do and how it improves the health outcomes of our patients that we see and the whole population that we serve. Our work is never done. We know there's always room for improvement, and even when we're rock stars, it takes work to remain at the peak of our game. The underlying premise of this work is that we can't improve what we don't know about, and we need to have some way of measuring both our baseline performance and whether the changes we make have true improvements in outcomes. This is just one of the studies that have demonstrated that we have significant gaps in what the evidence shows is good care and what our patients actually receive. Research studies and reports from the Institute of Medicine provide focus and urgency to our work of improving quality and safety for our patients. So who are the players in the quality space? Most of you have heard about NCQA, the National Center for Quality Assurance, but not everyone knows who they are or what they do. NCQA is a private, nonprofit organization that's been around for over 25 years. Their mission statement reports that they are dedicated to improving healthcare quality. They do this through a variety of programs for many different stakeholders, from insurance payer plans to practices like ours. Insurance companies report HEDIS metrics to NCQA, so the public can compare performance when choosing a plan, and payers can compare their performance to others and work to improve. You may or may not have heard of the Institute for Healthcare Improvement, or IHI. This is an independent nonprofit organization founded around the same time as NCQA, but has an international focus and really looks at how we can collaborate, work together across different healthcare systems to accelerate improvement and healthcare reform. The government has a big stake in quality. If you think about it, government, that's really our tax dollars, fund Medicare and Medicaid, which covers more than a third of all Americans. The Agency for Healthcare Research and Quality, or AHRQ, is the lead federal agency charged with improving the safety and quality of America's healthcare. HRSA, the Health Resources and Services Administration, is part of the Health and Human Services, or HHS. It's the primary federal agency for improving healthcare to our most vulnerable people. So where else is QI used? It may be easier to speak about the places in healthcare that are not involved in QI at this point. Clearly part of the entire healthcare IT movement through the Affordable Care Act that led to Meaningful Use program is founded on the premise of improving healthcare. As we move toward pay for value in MIPS and alternative payment models, Medicare is all about paying for quality. In the meantime, many of our private payers use pay-for-performance programs to drive quality improvement. Practice transformation around the medical home model, whether or not you choose to be recognized by the Joint Commission or NCQA, has measuring and improving quality at its core. Board Maintenance of Certification, or MOC, has an entire section developed to fostering, measuring, and evaluating quality in its Part 4 Improvement in Practice program. The Meaningful Use, or MU program, was designed to promote adoption of and improvement in use of electronic health records. All of this was done to improve quality, safety, and efficiency, as well as to reduce healthcare disparities. and ultimately was designed to move toward better clinical and population health outcomes. One could argue what the true costs and outcomes have been to the MU program and whether the return on investment has been demonstrated. But it's clear we are not going back to paper, and the move to improve quality using data is here to stay. Many practices across the state have at least one payer that offers a pay-for-performance program. High-quality performers can be rewarded in a variety of ways, but almost always result in real additional monies to the practice. This may come in the form of bonus payments. For my practice, our major payer will be rewarding us for our high-quality work with a bonus payment that covers more than one nurse's salary and benefits for the year. In addition, we got additional monies throughout the year as part of our monthly capitation checks. Some payers are intentionally narrowing their networks and terminating practices with low-quality performance. We haven't seen that as much in PA as in other parts of the country. But if your quality is not as good as your peers and there is network adequacy in your region, your patients may be forced to leave you for a higher performing practice. In some areas of Pennsylvania, there are payers who are giving patients lower copays to go to high performing practices. I've seen patients transfer to my practice because their out-of-pocket expenses are lower in our high performing practice. We will talk more about how to measure quality and collect data in the form of quality metrics, but to actually improve your quality takes more than collecting numerators and denominators. It takes a mindset of your entire practice, from leadership to every team member. There must be a mindset of, how could we be doing this better, from all dimensions of your practice. Quality improvement also requires commitment to the process. That means time to do the hard work involved and an understanding of why this matters. So where do those quality measures we alluded to in the previous slide come from? In general, they start from evidence-based research and are based on clinical practice guidelines. In most cases, there is a stakeholder group convened to build consensus. Those stakeholders almost always include practicing physicians, and many of the pediatric guidelines have included AAP members just like you. I've been asked to provide input into various quality measures over the past few years. The outcome does not always reflect my best guidance, but there is general consensus achieved by the stakeholders around the table. Quality measures can be developed by government agencies, private nonprofits, for-profits, and others. Some of our biggest struggles as pediatricians is that these measures are often adapted in some way by payers or health systems, and it seems like everyone wants their own customization of a national quality measure. While there is work being done at the AAP and in other organizations to harmonize and agree upon definitions of measures for children, this is ongoing work and will continue to require our willingness to be part of the process and not just complain about the outcome. In addition, sometimes the measures get used outside their original intent and have unintended consequences. For example, the chlamydia screening in women was originally intended to begin to measure the burden of chlamydia on at-risk adolescents in the Medicaid population. Unfortunately, there's no good way from claims data to define an at-risk woman, and suboptimal surrogates on birth control having had a pregnancy test were used. Additionally, in the Medicaid population, there is no risk of disclosure for parents getting an EOB. As this was widened to private payers, it began to have wider implications. So hopefully by now you're getting the picture that if you're not already involved in or getting geared up for quality improvement in your practice, you're at risk to have the healthcare system pass you by as you stand at the curb and watch the bus drive away. This concludes the first in the three-part series on quality improvement. We hope you have a good understanding of the forces behind quality improvement and recognize the organizations which develop, measure, report, and promote quality measurement and quality improvement. We encourage you to contemplate and discuss further as time allows.